Welcome to the installation and usage guide for the Affilion Charting System. In this presentation, I will describe how to install, print, and complete a template chart. Many medical staff members and consultants have expressed a dislike for the ED template charts. Their main issue revolves around readability. Specifically, the history of present illness is often difficult to decipher using the typical circle and slash method. Therefore, we've tried to create a blend of prose, which is appreciated by our colleagues, and templated items for speed of completion. To install the system, simply drag the folder labeled Affilion Chart System to the desktop or any easy-to-find location on the computer. Inside the folder, double-click the file acs.html. This will load a web page allowing users to select the desired template as well as other useful documents such as DKA treatment pathway and template admission orders. For the charts to display, you may need to install software PDF viewing, although this is typically pre-installed on most computers. Here is an example of what the web page will look like. Just click on any of the templates to display it in the browser. Chest pain, for example. Once displayed, click the Print button to print the template. The first page of the chart template is an order set. The orders will have the most likely needed tests listed, as well as areas for activating pathways and core measures. As you can see, the History of Present Illness section allows for prose text. Adjacent to the HPI section is a differential list with critical diagnostic considerations. Circling items that you will consider increases the complexity of the case, as well as serving as a reminder for important pathology that may exist. All gray background areas are risk reduction items or core measures. Please complete these as often as possible. If history is limited, check the box at the top of the page and provide a reason, such as altered mental status or acuity of patient's condition. For many items in the chart, use the circle and slash mechanism that is familiar to many template systems. Specifically, circle positive findings, slash items that are negative, and leave all others blank. Remember, for a level 5 chart, you must have 10 systems reviewed with at least 2 items per system. You can complete the review of systems individually, as shown here, or you can select the All Other Systems Reviewed and are Negative checkbox. The physical exam is created with most abnormal findings listed. Slash findings that you looked for but were not present, and circle any positive findings. For example, in a patient that does not have a cardiac murmur, slash through the murmur item under the cardiovascular section. Most common labs and x-rays are listed for completion. Remember to address the results of all diagnostic testing that you order. If additional space is needed, there is a section labeled Additional Information. The medical decision-making section is one of the most important areas of the chart. It is key that you are complete in detailing your thought process, but this does not require you to write a protracted dissertation. In this example, let's assume the patient is a 38-year-old male who presented to the ED for a brief 30-second episode of central chest pain with associated difficulty taking a deep breath, but no real dyspnea. We are all aware of the liability associated with patients presenting with chest pain, but some are simply low risk. To protect yourself and to demonstrate reasonable medical decision-making, we could write, The patient is a 38-year-old male with atypical chest pain symptoms who is low risk for short-term cardiac events. His initial and repeat EKGs remain normal and his troponin is negative. I've also considered PE as a possibility, but likewise feel the patient is very low risk and can be reasonably excluded considering risk assessment, Wells, history, and physical exam. At this time, I feel comfortable discharging the patient and have arranged prompt follow-up with Dr. Smith this Tuesday at 9:30. A brief statement such as this concisely shows complex decision-making while incorporating good medical care. Likewise, under the Treatment, Management, Rechecks section, write brief statements that are meaningful. For example, in our 38-year-old chest pain patient, we might document: given aspirin PO upon arrival, placed on O2. 1305, patient resting comfortably, pain-free. 1400, EKG repeated and is normal, patient remains asymptomatic. 1430, discussed all findings with wife and patient, all questions answered, follow-up arranged. Record consultations and include times as often as possible. Always create a clear follow-up plan and list any new treatments. Document with whom you discuss the care plan and record disposition location and condition. For diagnosis, it is important for your primary diagnosis to be distinct. Using phrases such as rule out or possible cannot be billed. For example, rule out MI is not appropriate, while chest pain is. Despite many advantages of a paper template chart, they are, at times, inadequate to convey needed information. In cases where a more robust discussion is required, I recommend a hybrid approach. Like a hospital discharge summary, dictate an ED case summary. This summary does not need to repeat information that is not essential or can easily be found in the paper template. Also, for admitted or transferred patients, a just the facts dictation can be very helpful for the treating physician. Here is an example of a case summary dictation. A 78-year-old female with 3 episodes of hematemesis since 07:30 this morning. No history of varices or cirrhosis. She has been using daily NSAIDs for her arthritis. The patient also had associated dyspnea but no chest pain. She reports some dark stools present over the last few days. Exam was significant for visualized bloody emesis of approximately 300 cc's. Abdominal exam was unremarkable. Stool was hemocult positive. EKG revealed some ST depression in the lateral leads. Chest X-ray was unremarkable. And specifically, there was no free air. Hemoglobin was low at 6.8. Metabolic panel and cardiac enzymes were unremarkable. The patient was treated with a bolus of protonics and started on a drip. I did not give octreotide or antibiotics since I felt it was unlikely that her bleeding was variceal. Due to the patient's age, EKG findings, and history of coronary artery disease, along with findings of active bleeding, blood transfusion therapy was initiated. I spoke with Dr. Jones and relayed the above. The patient will be admitted to the ICU with the diagnosis of upper GI bleeding, known coronary artery disease, and history of hypertension. A summary such as this can be done very quickly. It provides critical information to the admitting team and documents your medical decision making. In conclusion, the install process is easy and choose a convenient location. Once installed, choose the chart that best fits the patient's presentation. Document concisely and accurately using circles for positives and slashes for negatives. And finally, make liberal use of the hybrid chart for selected patients. If you have any feedback or suggestions, please feel free to contact me at ericwilkie@affilion.com.